Hello, my name is Corinne Barnhart, and for the final case connections in this course, I will be discussing cases 2 and 3. Case 2 is concerning a 4-day-old infant who has demonstrated elevated levels of phenylalanine with a reading of 6.6 milligrams per deciliter when the normal range is 1 to 2 milligrams per deciliter. A presumptive diagnosis was given to the infant of PKU, however, the baby's parents do not have a genetic history of PKU. When a person suffers from PKU, tyrosine becomes essentially a conditional amino acid. This is because tyrosine is synthesized from phenylalanine. Patients with PKU cannot consume phenylalanine, so because of this, they can become deficient in tyrosine without proper supplementation. The infant in question was given a phenylalanine dietary restriction at 5 days old, and she seemed to positively respond to the therapy as her plasma phenylalanine levels fell within the normal range. PKU is caused by a mutation in the enzyme phenylalanine hydroxylase, and this is a recessive condition, so it must be inherited from both parents. Deficiencies in tetrahydrobiopterin, or BH4, can also present similarly to PKU, as BH4 is a required cofactor for the metabolism of phenylalanine as well as tyrosine. A second infant is also suspected of having PKU. BH4 loading tests are done on both patients, which measures levels of phenylalanine. In patient A, the BH4 test shows an increase in phenylalanine levels over the 8 hours the test was performed. BH4 is thought to decrease phenylalanine levels in patients with PKU. Patient A does not seem to respond to the BH4 as their phenylalanine levels do not change significantly over the 8-hour period. This could indicate an incorrect diagnosis of PKU, and further testing would be required to rule out other conditions. In the second patient, the graph shows a significant decrease in phenylalanine over the 8-hour period, indicating that this patient likely does suffer from either PKU or BH4 deficiency and would benefit from the therapies targeted at those conditions, such as BH4 supplementation. For case 3, a 47-year-old man has severe pain in his big toe on his right foot, so much so that he is unable to bear any weight on the foot despite an apparent lack of trauma. The pain reportedly began the previous night and steadily became more severe. Based on laboratory findings, the patient is diagnosed with gout, and it is found that he has higher than normal levels of plasma urate and lower than normal levels of uric acid in his urine. Based on these clinical findings, it is most likely that his gout is caused by a decreased urinary excretion of uric acid. This is supported by the elevated blood levels of urate as well as the lower than normal levels of uric acid in the patient's urine. However, in order to determine this to be the cause, additional tests would likely need to be done to confirm. If the condition were solely related to the overproduction of purines, there would be an increase in the uric acid found in the urine because the body would excrete the excess. The body's inability to salvage purines would also not affect the body's ability to excrete excess uric acid, making the decreased urinary excretion of uric acid the most likely based on the information given. The patient also states that he has begun drinking high quantities of regular soda each day, as opposed to the diet sodas that he had been drinking previously. Regular sodas are typically sweetened with some form of high fructose corn syrup. Fructose is broken down and ultimately releases purines, which, when overproduced, leads to an overproduction of uric acid and thus gout. This particular dietary modification likely did not cause the patient's gout. However, it is very likely that the high levels of fructose greatly agitated an already existing condition by overloading the body with purines, causing the symptoms the man presented with and potentially making them worse or causing them to present more quickly than if he had not been drinking the high quantities of soda.